Without further ado, thank you for that. I can go ahead and I will introduce our speaker today, Dr. Mortazavi. So he is a dual board certified pediatric sports medicine physician who developed the first dedicated pediatric sports medicine program in Tucson, which is called the Sports Medicine, Rehabilitation and Concussion Center, also known as SPARCC. Dr. Mo specializes in complex concussion care for all ages and works to help patients living with brain injuries to lead healthy and fulfilling lives. So thank you so much for being here, Dr. Mo. The floor is yours.
Thank you, Brittany. Hi, everybody, and thank you for joining us. I'm Dr. Mo, and very excited about today's topic, which is the similarities that about 6 months ago, we started hearing about folks with long COVID and or maybe even a little longer when we first kind of started putting together, wow, a lot of these neurologic sequelae that folks are sort of talking about, the functional deficits in particular, sound very similar. And they sounded similar to a lot of our patients that we were managing at our concussion center that had post-concussive syndrome or persistent post-concussive symptoms. And so this became, at that point, a talking point for us. And since that time, we've sort of presented on this a little bit and also opened up our concussion center and some of the resources that we have, be it for cognitive testing or exertional testing or other things that we use for brain injury for some of these folks with long COVID. And I will be presenting on that small cohort that's sort of gone through our clinic as well after presenting some of the recent literature on this. So briefly about us over at SPARCC. So we, like I said, we've been doing comprehensive concussion care services or traumatic brain injury services for some time. Our center is a large 5,000 square foot center dedicated to really being able to have a multidisciplinary and comprehensive approach in terms of the types of particularly functional testing approaches we can have, as well as multidisciplinary treatments for these patients. So, and as I mentioned, that kind of segued into starting to see patients with long COVID, particularly with the focus on functional neurologic sequelae that they were having. We also have a sports medicine and rehabilitation clinic that's also multidisciplinary and do see many acute concussions, and we also have an ultrasound guided intervention team as well. This is the comprehensive concussion care team. We've got a relatively big group of multidisciplinary folks, which not only include the doctors and the providers, but also a combination of therapists, neurooptometrists, et cetera, to be able to deal with some of the rehab needs that are necessary. So our pediatric sports medicine team, and then as well as our ultrasound guided intervention team. So a little bit about me. So I went to medical school and undergraduate at UC Davis. I was an athlete there. I played football, so I've had my share of head impacts and head injuries. I did my fellowship at the University of Colorado, and also spent a couple of years while I was in medical school doing research abroad in Austria and Italy, and that's what those pictures are over there, where I also played some sort of amateur, I guess, football out there as well after college. So these are some images of me in residency, also at UC Davis. So I did a pediatrics residency before I went on to do my through the Family Medicine Board, my sports medicine fellowship, which entailed a lot of the concussion care stuff that I've done. That's my wife, who I met, who's a pediatrician at TMC. And the upper right is a trip we did together to Cameroon, and was really a wonderful several months over there treating the kids in the orthopedic ward, which is where I spent most of my time. And at the bottom right is the UC Davis Cal Aggie camp for foster kids that we did for a decade annually, which was also a phenomenal thing when I was up in Sacramento. These are, that's my kiddo. His name is Kai. I have two small kids, 5 and 6 now, and very, very blessed and privileged. So as we get into it here, no financial disclosures, and we'll sort of jump right into the talk here, and see how much we can get done in the next 40 or so minutes. So I always start with, with long COVID, this is still very much a, what is this, right? And I think there's a lot of people similar to persistent post-concussive symptoms that don't have a great grasp on what we're talking about. So, and long COVID is trickier because we've only been dealing with this for so long. And so the bottom line is the etiology, the incidence, and certainly the course, the timeline, the treatment, this is evolving evidence. And so I'll be sharing with you papers from literally a month ago that are coming out. And, as we speak, there's going to be more. So things are changing, and it's an evolving landscape. But basically, over the last year, really long COVID has established its definition as those with late sequelae, which really is defined more or less as around 4 weeks. Others have used sort of the 12-week mark, but basically 1 to 3 months and longer, is not expected for COVID. So now we're talking about long-term sequelae, which is actually very similar to concussion, right? We expect most concussions to be better, or mild traumatic brain injuries to be better under a month. And so once we get past that 1 month mark, we're looking at the definition of persistent post-concussive symptoms. So very similar to long COVID in that way. The nomenclature has bounced around, if you're going back to the beginning, post-acute COVID, long hauler, COVID-related chronic fatigue syndrome, all these different terms have been used, but really we're trying to shift towards having one consistent term in terms of the nomenclature, and long COVID is really the one that we're sort of all running with at this point. It can hit a variety of organ systems, over 10 organ systems and symptoms in all of those, over 50 plus symptoms. The research is still very limited in particular in terms of treatment and management in this group, because those require and I'm talking for the non-specific sequelae, right? And those kinds of studies interventional studies require more time. So a lot of what we have so far is more retrospective, cross-sectional, survey-based studies. So defining the problem, how big of a problem is this exactly? So if you're looking at the literature, the COVID symptom study is a huge study, international, from the UK, and it's basically, I think, the best source to look at, okay, what is the incidence of this based on what's being reported out there? And it appears to be somewhere between 5 to 15%. When I first presented on this, the data was 5 to 10%. So you can see that if there is a trend, it appears to be in the direction of, okay, maybe this is more of a problem than we think. And as I share with you some of the most recent literature that's come out, like the Wuhan study, we'll see that there's a suggestion that there are probably more people that have long-term sequelae than we think. But 5 to 15%, I think right now is a pretty good understanding. And again, if you're comparing that with mild traumatic brain injury or concussion and prolonged symptoms, pretty similar. We, in the current literature, we quote that to be around 20%. So again, a lot of similarities there. As I mentioned, the current guidelines from the CDC and the NICE guidelines, really looking at if the symptoms are prolonged more than 4 weeks, we need to be looking at the possibility of long COVID. Again, a variety of symptoms, 10 different organ systems. My focus today, obviously, is going to be on the neurologic sequelae. And neurologic, cardiac, pulmonary, and psychiatric are the big players of all those organ systems. So, and I may be biased to neurologic, but I feel like when you talk about complexity, particularly of non-specific functional sequelae, neurologic is where it's all at. So, and we'll talk a lot about that. Here was a relatively, early chart out of a JAMA paper in the CDC, sort of, again, more or less, this is back in 2020, looking at late sequelae or long COVID. And at that point, pointing out that the pathophysiology is mostly not understood or proven. And that's still true, but there's a lot more that we know about it now than we did then. And again, the sort of the major players being cardiac, pulmonary, neurologic, and psychiatric. So this was also from the CDC, pointing out all the different organ systems and the different sort of areas where we can see problems with long COVID. And again, for the scope of this talk, the focus is going to be on the neurologic. And for good reason. So if you look at the symptoms in all comers here with long COVID, by far the common thread, the common theme is this concept of fatigue. Okay, and it's not just, and you can see fatigue and dyspnea are your top two symptoms, right? And but it's not just physical fatigue, right, which can be manifested with exercise intolerance, etc. But it's also this concept of cognitive fatigue. A lot of people will complain of cognitive fog, some cognitive impairment, difficulties with memory, et cetera, et cetera. So the fatigue concept that can be broken down into mental and physical really is where it all starts for all comers. So if you're looking at it that way, yes, there is, other symptoms, with respect to joint pain, chest pain, et cetera, and those all need to be addressed case by case. But majority of the patients with long COVID are going to have this fatigue, mental and physical, and that's going to be a common theme of, although maybe not every time, but what's going to need to be talked about and addressed in these patients. So here's a paper from Townsend, basically looking at this fatigue concept. They looked at, and this was still also relatively early on, looking at fatigue, which was in greater than 50% of patients with long COVID beyond 10 weeks. And this was independent of severity of illness or hospitalization. And again, this will be another critical common theme in this talk, which is this doesn't just pertain to people that were in the ICU or hospitalized. We are seeing long COVID in folks that had relatively mild illness. Maybe even they thought their illness resolved, and then later they started seeing these issues. So, and we're specifically with the fatigue getting into non-specific neurologic symptoms, which has been looked at in multiple studies. And they kind of break down into these three categories: physical, so the headache, visual disturbance, mobility, balance issues; cognitive, more of the memory, cognitive fog; obviously hearing loss, smell, taste issues, which are less common, but pretty pathognomonic. And then the mood and behavioral symptoms, including PTSD, which we've seen at pretty high rates, in particular, in actually the younger patients. So, and again, that those of you that are involved in brain injury or post-concussive, you'll look at that and you say, oh, that all sounds pretty familiar. Now, cardiopulmonary, those are obviously very serious symptoms that we need to make sure we're ruling out a specific pulmonary or cardiac disease, such as pneumonias, myocarditis, cardiomyopathy, et cetera. And those symptoms are often going to be your dyspnea, cough, exercise intolerance, which is much more nonspecific. But we actually see specific cardiopulmonary disease much more in the hospitalized ICU patient. So that's important. But that's not to say they can't be in those that had milder disease. And ultimately, with these long COVID patients, particularly with those type of symptoms, but anyone with exercise intolerance as well, we need to rule out cardiac and pulmonary specific disease before we move on to doing some of the other things we do for these patients.
Before you jump too much further, I do have
Sure.
a quick question in the chat, if you don't mind.
Yeah, no problem.
Jeff is wondering if people who have that pre-existing brain injury, as you said, those symptoms look familiar to them already, would they be more at risk for developing either A, long COVID, or B, the neurosequelae that you're discussing here?
Yeah, I mean, that's a fantastic question. And the simple sort of postulation to the answer is yes, because those are systems that are already struggling, and then you take another hit. The problem is we haven't had enough time to study this using good research to prove it, right? So I can't tell you, yeah, we've looked at that and that's exactly right. There's, only so many people that are going to have had an existing. I certainly have those patients in my clinic who have an existing post-concussive syndrome and then develop COVID on top. And we absolutely see an exacerbation of their symptoms. And in some cases, it appears to overall just worsen their course. In some cases, they sort of rebound back. So we just need more studies to really be able to answer that question. But, on face value, you've got one neurologic insult that's traumatic, whether you're still dealing with it or you just have a history of it. And then you've got another potential neurologic insult that's coming more from an infectious etiology. So, but do the two compound? Probably, right? We just haven't had a chance to really look at that with high level evidence yet.
Better safe than sorry. Avoid being infected at all costs. That's probably just a good rule of thumb.
No,
right?
I definitely don't wish long COVID on any of my patients, particularly that are still dealing with post-concussive syndrome. I mean, I sort of bite my lip when I hear about that. But I will say they don't all. Some of them they're dealing with prolonged symptoms. They get the they get the COVID infection, and then they sort of bounce back to their pre-infection symptoms, in a couple of weeks. So I think the real question is, if we look at that in more of a, sort of a longitudinal study, or even a cross-sectional study where we can go back and look at big numbers and really figure out, what is the impact of getting COVID on top of an active recovery process for brain injury, versus maybe the question was also getting into somebody with a history of brain injury. Do they also have a predisposition towards long COVID? I think those are all great questions and great ideas. We just don't know. We have to study it first. So,
all right. Well, thank you for that little rabbit trail.
Yeah, absolutely. So now getting into sort of the cognitive impairment. So this was a study done relatively early on as well, a large multi-center international study looking at a variety of COVID presentations and a really large number of patients. So not just severe, but everything from mild to all the way out to ICU type of presentations. And basically, I think that the key here is that they saw cognitive impairment, high rates of mild cognitive impairment overall, not just, again, in those that were hospitalized or ICU. They did see higher rates in those folks and higher degrees of cognitive impairment. However, when they implemented cognitive testing in folks that had COVID, they still saw a relatively high rate of at least mild cognitive impairment in those that had COVID and COVID with persistent symptoms. So, and the suggestion here is that particularly if someone is complaining of ongoing cognitive fog or cognitive impairment, no matter how mild or non-specific it may seem, it probably isn't a bad idea for them to have a cognitive assessment. And there may be some management that might be necessary with respect to whether it's accommodations for school work, neuropsych evaluation, or even cognitive therapy. What about exercise intolerance? So this is also relatively common in the long COVID folks. And you can see over on the right, 3 relatively recent papers that have looked at this, although there's a plethora. And so it's about 30 to 50% in those that have long COVID will complain of fatigue that's more exertional and consistent with exercise intolerance, meaning they're not tolerating their previous level of exercise. And so, and again, most of these, although we need to rule out specific cardiopulmonary disease, most of these patients don't have that. They get the rule out, which is important, and they don't have myocarditis or specific pulmonary disease or pneumonia or whatever. And they actually have preserved pulmonary function tests and preserved cardiac function. A number of these studies have looked at this. But when you get into more of the functional nitty-gritty of exercise tolerance, you do see limited aerobic capacity and VO2 max compared to healthy controls. That was a very recent study done by Singh in 2021. Also, abnormal ventilatory efficiency, systemic oxygen extraction was noted to be limited in this group, as well as peripheral vascular resistance, which could suggest some autonomic dysregulation in the long COVID group. That was a study done by Alba also recently in 2021. So, I think when we start to look at exercise intolerance in this long COVID group closer and look at all the different papers that are out there, what you see is that dysautonomia or autonomic dysregulation remains a key player as a possible underlying etiology for this. So, and that's, I think, an important thing to keep in mind, because there's questions that can be asked and simple tests that can be done, like orthostatic testing, sort of assess for autonomic dysfunction. And if this could be a factor in those that are having exercise intolerance that's not otherwise explained by a specific cardiopulmonary condition. So is there a way we can sort of do some basic assessment, or you guys that work in your clinic can do a basic assessment for exercise tolerance to really figure out if they need more extensive testing, like an exertional tolerance test? So I think it's all starts with a thorough history and really sort of asking the detailed questions that gets into exercise tolerance. And I think one of the keys is understanding what someone's baseline is. So I always ask people, I say, well, what level did you used to exercise? What kind of things did you used to do? And how are you doing now? And if there's a big disconnect there, I want to ask them why. And if they tell me, well, because when I start working out harder, I get dizzy and lightheaded and I just can't do it. That's one thing versus them saying, I don't have time, right? Or whatever. So I think it's important to ask about their baseline level of exercise, where they are currently with exercise. I get dizzy, lightheaded. Those are postural symptoms that could be suggestive of autonomic dysfunction, and again, can be tested with some orthostatic testing. So getting into some, kind of what I call a poor man's exertional tolerance test, the sit to stand test, which, number one, you need to sort of make sure your patient doesn't have any absolute contraindications to doing, a simple exertional test. And if they don't, then you can do this sit to stand test in the office. It can be as short as 30 seconds if you've got someone who doesn't have a lot of tolerance and is older, or it can be as long as 5 minutes. And basically you just have them, do like this in this picture the lady's doing, cross their arms and sit and stand and sit and stand, at a pace that they're comfortable with. And you're basically documenting in a certain amount of time how many times they're able to do that. And if you're able to monitor them for symptoms and get a pulse ox on them so you can monitor their heart rate and oxygen saturation, that can give you some pretty critical information in terms of, are they having some significant exercise intolerance without having a lot of tools and resources to do formal exertional testing. The 6-minute walk test is another one I'll touch on in a second that can be done around the office. But this is a study that was done comparing the sit to stand test to the six-minute walk test. And actually they're pretty comparable. So either one can be done if you don't have a space that's conducive to them walking around for 6 minutes. So, and then orthostatic instability can be assessed relatively easily by having them lay down, getting a blood pressure, having them staying flat for 5 minutes and then stand up, and then basically obtaining pressures at 1, 3, and 10 minutes. And with that, of course, you're obtaining the heart rate as well to assess for POTS, or postural orthostatic tachycardia syndrome, which is another form of autonomic dysfunction. So you can, and I think it's also important if you're doing orthostatic testing, which can be done again in a matter of 5 to 10 minutes relatively easily without needing $1 million tools. All you need is a table and a blood pressure cuff and a heart rate monitor. But you also want to ask them about symptoms. So when you have them laying down for 5 minutes and then they stand up, if they endorse symptoms of dizziness, pre-syncopes, palpitations, those kinds of things, that's also important to document, even if their numbers look okay. So, and just as a reminder, the orthostatic numbers, if their blood pressures drop by more than 20 points systolic, 10 points diastolic, and then if their heart rate shoots up more than 30 points, those are sort of the cutoff for orthostatic hypotension or POTS. So, and that's, that's all easy information to obtain. So, so what about indications for formal testing? So basically the previous slide are ways that you can sort of get a better assessment. And if any of those are positive, then you've got an indication for referring them for formal testing. Okay, whether that's to cardiology because you're worried about cardiopulmonary, or whether that's already been done and ruled out and they still have exercise intolerance, and that needs to be addressed. And that's something that we can help with because it's probably coming from a neurologic sequelae at that point. So, but again, number one, we got to rule out specific cardiopulmonary disease in these patients. If the symptoms of exercise intolerance are not otherwise explained by your workup, which we'll talk about as well, there should be a laboratory workup and all that. And they're not tolerating, and some of these patients will tell you, I can't even go up and down the stairs anymore or down the block anymore without getting tired. So certainly if they're not tolerating their regular activities of daily living, that's a red flag. If they're not even close to their baseline exercise intolerance and you don't have another reason for it, that's a reason. And new postural orthostatic symptoms that they didn't have before. right? So the long COVID could have created some dysautonomia, which is causing those symptoms, and as a result, causing the exercise intolerance. Those are all things that are indications for formal testing. And then others would be actual signs of exercise intolerance on any of the testing you're able to potentially conduct in your office. An abnormal sit to stand test, a 6-minute walk test that's abnormal for their age. And you can look into the bottom right, we have charts for both of those tests with what the expectations should be, or abnormal orthostatic testing. So. Okay, what about psychological symptoms, or looking at the mood and anxiety and the, psychiatric components of this? Again, very common: mood, behavior, sleep dysfunction, up to 50 to 90%, depending on what study you're looking at. Anxiety and mood, as you can see in the chart in the upper right there, are your most common, and sleep disturbance, as you can see, this is from Davis's study, which I'm going to present to you shortly. This is a more recent study, a couple of months ago, a large trial that was done, international trial that was done. I'll get into the details of the study, but they looked at mood, behavior, and sleep very closely with their study as well, and found that sleep disturbance was as high as 30 to 60% in those with long COVID. So these are areas that can often be neglected, often not discussed, but it's very important that that doesn't happen in this patient population, because it's very common and it can create a major problem with all the other areas as well. So we want to make sure that we recognize that mood and sleep dysfunction can have a very strong impact on cognitive, on exertion, on this concept of fatigue. So we need to be really asking, and if they have major issues in these areas, they need to be addressed. Otherwise, it's going to be very hard to address the others. And I'm going to segue right to Davis's study, which recently came out in July 2021. And this was again an international survey, over 3,000 patients with long COVID, over I think 50 countries or something like that. So a large sort of international survey-based study that was done, and they used 28 days as their cutoff for long COVID. So, and here's what they found. So on average, these patients endorsed 25 to 50 symptoms in about 9 different organ systems, but only 8% of this cohort in this survey study were even hospitalized. So again, 92% fall into that category of non-hospitalized, non-ICU, or what we would call more of the mild to moderate disease. However, when they looked at resolution, what they found was that 91% were still unresolved at 35 weeks, which is close to that 7-month mark. So that's pretty significant for this long COVID group. And that fatigue, exercise intolerance, and cognitive dysfunction were the top symptoms after 6 months in particular that were persisting. 88% reported cognitive dysfunction and memory deficits on their survey data. 45%, or about half, basically said that their work level had to be reduced because of their cognitive issues, and possibly some exertional. And then a quarter of them weren't working at all. They were basically on disability and could not work. 30% reported POTS, or postural orthostatic tachycardia syndrome, which is a form of dysautonomia that the patients can actually measure for themselves. And the way it was done in this study is they would ask them when they get up to actually monitor their own pulse. And if it went up more than 30 points, they basically were documented as having reported POTS, although this was not obviously done by a physician. 85% also reported frequent symptom relapses, that they had this sort of waxing and waning type of a picture, which for those of you, again, that deal with post-concussive syndrome and mild traumatic brain injury with prolonged symptoms, again, this probably sounds familiar, because it certainly does to me. Many of my patients have these flares and waxing and waning courses before they fully recover. And certainly in this group, by far the majority were reporting that they were having relapses, particularly related to cognitive, exertional, and different stress type of triggers that were causing their relapses. Here's another even more recent study. This is the Wuhan study that I alluded to at a Lancet, which just came out in August of 2021. And this was a one-year cohort study. And this study not only involved survey data, but they actually had these patients coming back in for assessments and objective testing. So in total, they had 1,276 long COVID patients, and they received evaluations at 6 and 12 months. So there was both visit and survey data on this one. And they also had over 3,000 matched controls to compare with. Originally, they had about over 2,000, 2,500, something like that, patients, all from the same hospital that were discharged from the same hospital with COVID, where they did both outpatient and inpatient assessments. But it was only about 1,276 that they were able to follow through with the 6 and 12-month visits. So that's basically who they included in their study. And here's the outcomes, which are, or the results, which are very interesting. So, and I've kind of highlighted a few of the points here. So 49%, basically half, okay, half of these patients with long COVID still had at least one symptom at 12 months out. Now that was improved from 68% at 6 months, but still it's kind of scary to think at a year out that, half of these patients are still having some form of sequelae, although a lot of those may have been pretty mild. Fatigue and muscle weakness were the most common symptoms. So again, a relatively common thread theme there with this fatigue, physical, cognitive piece. 30% reported persistent dyspnea and at 1 year. So and what I mean by persistent is that at 6 months, it was about the same, 26%. So dyspnea was something that we weren't seeing improvement in this study in that 6 months between the 6-month mark and the 12-month mark. An objective test, the 6-minute walk test, was done in these patients at the 6-month and the 12-month mark. And no difference was noted in their performance on the 6-minute walk test, which gives you that objective part to go with the subjective component of persistent dyspnea or exercise intolerance. They also saw persistent diffusion impairment testing that was done in about 25 to 50% of the patients at 1 year compared to 6 months. 26% had, again, persistent mood and anxiety problems. We saw this at 23% in this population from China at 6 months. And it was about the same at 12 months, just like the exercise intolerance was. And so I think the key point in that persistent piece is they just weren't getting better just because time went by, right? And in this group, there was no intervention, right? They were just following these folks and checking their tests and their symptoms at 6 and 12 months. But you can see that although the overall symptom burden might have gone down from 68% to 49%, however, there were certain components that weren't just necessarily getting better with time, right? And that suggests that intervention for those mood and anxiety symptoms, that intervention for exercise intolerance becomes important. And that's all going to be through multidisciplinary rehab and therapy. So, and finally, this group, when compared to the control group, showed that they had significantly worsened quality of life, dyspnea, mood and anxiety scores compared to the control group. So, and the control group was selected to match the group that was included, obviously minus the COVID infection. So, see if we can keep this moving here. Okay. So, so long COVID in primary care. So I think this was a relatively early study in BMJ that came out sort of, and I like it because there's a really nice schematic here on the right that's from the paper that sort of showed us, at least initially when people still didn't really know what long COVID was, sort of how we could do a bit of a workup to assess for this in folks that have prolonged symptoms. So complete history and exam was noted as an important thing, appropriate workup based on the history and physical, and ruling out specific disease, particularly things like stroke, encephalitis, cardiac disease, pneumonia, PE or pulmonary embolism. And there's a laboratory workup and chest X-ray workup that was documented and mentioned in this paper that the NICE guidelines more recently, I think, have a much more comprehensive approach on that I'll show you shortly. But bottom line was, okay, if they're having problems and their laboratory workup and imaging and all that looks normal, which they often do, and they're having ongoing functional sequelae, well, supportive care is where we need to be. And that's going to be, a combination of counseling, meds, home rehab exercises, et cetera. And at that point, our questions were, okay, but what else? What else? What are other options out there? What else can we do for these patients? So the NICE rapid guidelines are a great set of guidelines out of the UK. And this is about a 26 to 30 page document. You guys can Google this, you have access to it. And I think it's a great document to sort of look at the sort of long COVID rapid guidelines in terms of the management and evaluation. So, and it's, it's kind of the 2.0 of what the BMJ article was. So basically, they're suggesting initiating this somewhere at 1 to 3 months, where we are identifying that long COVID is indeed what's going on here. And that a holistic, thorough history is very important, with a focus on functional impairments, because that's often what we see, as opposed to just ruling out specific disease and then saying, well, you got functional problems, we don't know. And then from there, diving into specific functional issues that we know are very common: cognitive, exertional, intolerance, mood. If we can't talk about these things, then not much is going to come of these visits, right? Because majority of what's happening with these long COVID patients are going to be non-specific functional sequelae in these areas. So we need to be able to talk about mild cognitive impairment and how that's manifesting for them. We need to talk about how long they used to be able to work. And, I've had patients do, I used to be able to, handle 8-10 hours of work, no problem. Now, after 3 hours, I'm running out of gas. I don't know what's going on, right? Those are the conversations we need to have on the cognitive front, on the exertional front, and also the mood psychiatric front as well. There is a laboratory workup that's recommended here. Ultimately, the goal, again, is to rule out specific disease. Generally, x-rays should be obtained as well. Appropriate referrals. So oftentimes our specialists here include pulmonology, cardiology, neurology, et cetera. But bottom line, multidisciplinary rehabilitation appears to be the most common critical direction that we go into for what most of these patients are suffering with, because most of it ends up being, again, non-specific disease and it's functional impairment that needs rehabilitative or neurorehabilitative treatment. This I just wanted to add, because I've gotten a lot of questions about how vaccines affects things and all that. So vaccinated status definitely reduces, and this was a very recent paper out of Lancet looking at long COVID risk being reduced by half in those that are vaccinated. So it doesn't mean it can't happen. I'm vaccinated. I can obviously get COVID, but I'll feel better about the fact that, number one, I have a reduced morbidity based on the vaccine, and then number two, a reduced risk of developing long COVID, and certainly reduced risk of mortality. So. Okay, so this is our cohort. So, I just wanted to present a little bit of data on these 9 patients that we've seen in our clinic, and sort of give you guys a glimpse of what we do and what we're seeing. So this was 9 adults. Average age was 44 years. Luckily, I really have not seen a lot in my clinic anyway. A lot of long COVID in the pediatric population. So, I'll sort of touch on that in a bit, the little bit that we have seen. But this particular cohort was an adult cohort, 44 years of age on average that we looked at. And they had long COVID with a range of presenting to us at 4 to 12 months. Okay, so they were significantly out there in terms of by the time they came and saw us. They weren't just at 1 month, and they were presenting with a mild to moderate level in terms of total symptom score. And we actually were using a validated screen that we use for brain injury, the CP profile out of UPMC, which dives into, it's about 29 questions, but dives into cognitive, exertional, visual, vestibular, mood. So it's a very comprehensive screen. And so we had the ability to ask all those questions with this validated screen. Work intolerance was on average of these folks, we have sort of levels from 1 to 4, 0 being no work, 1 being really relatively part-time, like even under half-time, 2 being half-time, 3 being half to full, and 4 being full-time. So on average, these patients were under half-time in terms of what they were tolerating with work, and a third of them were out of work completely on disability by the time we saw them. Computerized cognitive testing is one of the resources we have to be able to do some cognitive testing, like that study I showed you earlier that had looked at that in a large number of patients. And we did see cognitive impairments in 7 out of 8 that actually did the cognitive testing. 1 of them did not. Evoked potential, or QEG, looking at P300 evoked potential, did show suppressed P300s in about 6 out of the 8, or about 75% of the patients. And what the P300 is a neurophysiologic test to look at cognitive resources and cognitive capacity. So we did see a suppression in this group. We just happen to have that tool for our traumatic brain injury cohort. So it was something we could use in this cohort. It's pretty novel. It's not something you're going to find in the literature. So we hope to, as we build on this cohort, publish our data over the next few months, certainly by the end of the year, and get some of this information out there. What about exercise intolerance here? Sorry about that. I'm clicking around a little bit. So we did look at this. We do formal exertional testing in all of our patients with TBI. So we had, again, those resources to look at this in this long COVID cohort. And what we found, that exercise intolerance was there in 8 out of the 9. Only 2 out of the 9 tolerated heart rates that were greater than 120 beats per minute, which is a, pretty, even for the age that we had, still a pretty light level of exertion. So only 2 were able to sort of get into that more vigorous zone. Most of them were only tolerating light exertion, light to moderate, depending on their age. And so exertional rehab dose, based on their tolerance, was still assigned, because one of the key multidisciplinary rehabilitative approaches is to utilize exertional rehab in these folks to build up their exercise tolerance, just like we do with post-concussive. So we did assign a exertional rehab dose based on their tolerance and based on where their threshold was. We're usually about 10% below that threshold, to all the patients, and to really use exercise as a key component of their rehabilitation and their treatment. Autonomic dysfunction, which we assess for every time we do exertional testing, with a combination of orthostatics and some cardiovagal tests, was seen in 5 out of the 9. So pretty significant amount did have autonomic dysfunction. In our traumatic brain injury patients, it's less than that. It's probably 20% or less even. So, and then the vestibulocular motor screen. This was also something that it was relatively novel. I have not seen a whole lot, especially with specifically using objective testing in long COVID patients looking at vestibulocular motor. Certainly the symptoms are suggesting that these patients are saying they're having oculomotor and balance issues. But we actually tested it, because we have the capacity to, and we do a vestibulocular motor screen on every patient, every visit for traumatic brain injury. So it's an important screen, validated screen out of UPMC that we use. And what we found is that there was abnormalities on this screen, and it was positive in 7 out of the 9 in this cohort. And what we meant by positive is at least 2 of their tests that the vestibulocular motor screen involved were positive. So, and what we saw on average in our cohort is that they had about 2.2 of the 3 tests that we do that were positive. And then the near point convergence, which is part of the vestibulocular motor screen, specifically, we pulled that out because that's a very easy quantitative number to pull out. And on average, this group had a near point convergence of 15 centimeters. And for those of you guys that are familiar with near point convergence in TBI patients, 6 to 8 centimeters is the upper limits of normal. So if we're seeing 15 in a TBI patient, we know that that's probably abnormal. And certainly in this long COVID cohort, that's the thought process that they're near point convergence. Although we didn't see this in every patient, on average, it was long. So we did see it in the majority of patients where they had oculomotor issues as well. King-Divid is another oculomotor sort of crude cognitive test where they're reading numbers off of a card and we're timing them. And 22.3 seconds was on average what their times in this adult group, what their times looked like for the first card. And the normative data on KDs is closer to 13 to 15 seconds in this age group. So definitely also a similarity to what we see in the mild traumatic brain injury group, where we do King-Divids and we see abnormalities. We did actually an abstract several years ago, looking at those with concussion that were higher risk to have prolonged symptoms. And two markers we looked at was near point convergence and KD scores. And what the study, the abstract that we did show is that if the near point convergence was greater than 15 centimeters and the KD cards were on average greater than 20 seconds, they had a significantly higher rate of having prolonged symptoms. And what's interesting is, so far in this small cohort, we're seeing similar numbers in the long COVID patients. So we do also have an oculomotor tracker in the clinic, which we used on 5 of the patients, and 3 out of the 5 had significant abnormalities, looking at specific components of oculomotor tracking, like pursuits and saccades and fixation. So, this is a nice schematic looking at the post-concussive domains. I kind of alluded to this earlier with the intake form that we use for our mild traumatic brain injuries. We will really want to be asking questions in all these different profiles, right? Not just about headaches, but also about vestibular, visual, cognitive, mood, sleep, exercise intolerance, cervical. And so essentially this model, particularly when you're talking about neurologic sequelae of long COVID, is not a bad model to be able to sort of use and sort of move over to the patients that are having these long COVID symptoms. I talked about pediatrics and long COVID. This is a case example of a teenager. We've seen a few teenagers. 16 was the youngest we've seen. And this was a healthy girl who had mild COVID, 5 days of symptoms, no fevers, no hospitalization, seemed to get better from it, but subsequently developed some severe chronic fatigue. All of a sudden wasn't tolerating school well. I apologize, I'm just going to make sure my battery doesn't run out here. Wasn't tolerating school well and was complaining. Can everybody still hear me okay? Sorry about that. Okay. And was complaining that she was having issues with fog, memory, a lot of difficulty with screen time, and was a track runner, and was saying, I used to run the 400 meter, but now I can't even get out. All I can do is walk. So was having all these sort of non-specific symptoms, had a thorough workup, all of which was negative for specific cardiopulmonary disease or brain MRI looked okay. So, and this was, an example of a patient that presented to us and we're trying to work with. So let me I don't know why I'm kind of stuck here. Let me just see if I can.
Sometimes if you press like the escape button, it'll take you back to the original screen and you might be able to go to the slide you want to.
Okay. See an escape option and I'm pressing it. I think you're right, because I can't even find my mouse right now. If there's questions, this maybe isn't a bad time until I figure this out. I'm getting down to the end anyway, and hopefully my computer is just kind of spazzing out for a second and it'll resolve here in a minute. But if there's questions, I'm happy to answer them.